Hello. My name is Dr. Francois Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SCFO. In this video, I want to talk to you about the mechanisms of action of spinal manipulations for the muscles. This series of videos will look at the scientific literature surrounding the mechanisms of spinal manipulations, mostly used by osteopaths and chiropractors. In these videos, we will study the mechanical mechanisms of HVT, action for disc hernias, and the effects they have on the peripheral and central nervous systems, the neuromuscular, neurovegetative systems, and on the organs, biological effects, and so. In this video, we are reviewing mechanisms of action of spinal manipulations with HVT for the muscles. This study by Dunning and Rushton, 2009, demonstrates a single HVT to the right C5-C6 zygapophyseal joint elicits an immediate increase in resting EMG activity of the biceps bilaterally, irrespective of whether or not cavitation occurs. The graph on the left shows the mean and 95% confidence interval for the percentage of change in resting EMG activity of the right and left biceps brachii muscles following HVT manipulation to the right C5-C6 facet joint. According to Bicalho et al., 2010, the results of a manipulation at the L4-L5 level suggest that HVT manipulation is able to acutely reduce abnormal EMG activity during the full-flexion static phase and activation during the extension phase of the trunk. The graph on the right shows the percentage change in the flexion-relaxation ratio from baseline to the final assessments for the control, light, and manipulation, dark, groups. Values are calculated from the EMG signals from the right and left paraspinal muscles individually, and from the average of both. McChesney et al., 2011, indicated that manipulation of the thoracic spine does not significantly alter the myoelectric activity of lower trapezius and posterior deltoid muscles during treadmill walking. The graph shows the mean EMG activity of posterior deltoid muscle during 2 minutes of treadmill walking, before and after interventions in control. Sham ultrasound reduction of 18.5% of mean integrated EMG, and experimental HVT reduction of 14.9% of mean integrated EMG. The study by Lehman et al., 2012, showed that HVT manipulations have been associated with changes in muscle activation, near to, and distant from the spine, for the example, the muscles in the upper limbs. Rather than the typical reduction in muscle activity, an increase in resting activation has been reported. The study by Nagaru et al., 2014, indicates that increasing preload forces led to an increase in neuromuscular responses of thoracic paraspinal muscles and vertebral segmental displacements during the preload phase of spinal manipulation. Increasing the preload force also yielded a significant decrease in sagittal vertebral displacement and paraspinal muscle activity during and immediately after the thrust phase of spinal manipulation. Changes observed during the spinal manual therapy with thrust phase could be explained by the proportional increase in preload force or the related changes in rate of force application. The present results suggest that neuromuscular and biomechanical responses to spinal manual therapy may be modulated by preload through changes in the rate of force application. The picture shows typical EMG and kinematic responses throughout the various spinal manual therapy time windows, defined in the Methods section. The results of the study by Suter et al., 2000, suggest that sacroiliac joint manipulation reduces knee-extensor muscle inhibition. Spinal manipulation may possibly be an effective treatment of muscle inhibition in the lower limb musculature. These four graphs show the changes in EMG of the muscle inhibition in lower limb, in treatment group and control group. The study by Barbosa et al., 2014, shows that sacroiliac joint manipulation immediately improved the electrical activity of the transverse abdominal and internal oblique muscles during rapid voluntary upper limb movements, suggesting improved segment stability and an increment to the afferent stimuli in order to affect the motor response. This table shows the results of the Pearson coefficient, R, significance, P, and level of correlation in ipsilateral, I, and contralateral, C, abdominal muscles, before the intervention, A1, and after the intervention, A2. Herzog, 2010, measured EMG activity, within 200 and 400 milliseconds following the onset of the treatment thrust. Muscle activity disappeared following the treatment thrust, and was not observed during preload application, suggesting that this was indeed a reflex response, and that the reflex response was associated with the speed of force application. According to Grindstaff et al., 2009, the group that received a lumbopelvic joint manipulation demonstrated a significant increase in quadriceps force, 3%, and activation, 5%, immediately following intervention, but this effect was not present after the 20 minutes interval. The picture on the left shows quadriceps maximum voluntary isometric contraction force. Values are expressed as % change from baseline and standard error of the mean. Asterisk is significant from baseline to p greater than 0.05. The objective of this study by De Vogt et al., 2005, was to examine the effect of spinal manipulation on EMG activity in areas of localized tight muscle bundles of the low back. Electromyographic activity decreased by at least 25% after treatment in 24 of the 31 sites that were monitored. There was less than 25% change at 3 sites, and more than 25% increase at 4 sites. Multiple distinct increases and decreases were observed in many data plots. The results of this study indicate that manipulation induces a virtually immediate change, usually a reduction, in resting EMG levels in at least some patients with low back pain and tight paraspinal muscle bundles. In some cases, EMG activity increased during the treatment protocol and then usually, but not always, decreased to a level lower than the pre-treatment level. In this figure, the lowest level of EMG activity represents a period of resting, which oscillates for almost 5 minutes of data collection. The EMG at the end of the resting period is somewhat lower, less than 2 microvolts at 290 seconds, than at the beginning. It was generally greater than 2 microvolts in the first few seconds. The large range of EMG activity probably represents voluntary movements made by the patient. The gray line, representing the accelerometer, shows the beginning of the spinal manipulation. Small, but perceptible, drops in activity can be observed very soon after most of the thrusts. Other small drops occur where there has been no thrust. The gray line representing the accelerometer shows the beginning of the manipulation. The first 2 thrusts shown were applied at the base of the sacrum, The accelerometer did not pick up the third thrust at the base of the sacrum, applied between 5 and 7 seconds. The last 3 thrusts shown were applied to L5, L4 and L3, respectively. The drop seen at 20.9 seconds represents an interruption in the collection of the data, which was paused for approximately 4 minutes until treatment protocol was completed. According to Cao et al., 2013, thrust displacements applied during an HVT spine manipulation produced sustained increases in the resting discharge of paraspinal muscle spindles, regardless of the duration over which the thrust was applied. This diagram on the left shows the afferent response of the cervical neuromuscular spindle to a rapid rotation of the C2 vertebra, which simulates the thrust phase of an HVT manipulation. In each section, A, B, C and D, the top line shows the original activity of the neuromuscular spindle. The middle line shows the instantaneous discharge frequency, and the lower line shows the relative position of the C2 vertebra. A shows a decrease in the afferent activity of the neuromuscular spindle during the thrust movement. B shows an increase in its frequency during a displacement to the right. The 2 lower lines show the response of a neuromuscular spindle to vertebral displacement to the left, then to the right, and finally returning to the midline, C, and then the inverse displacements, D. Bear in mind that the displacement on the line showing the original neuromuscular spindle activity is greater when the vertebra is displaced contralaterally. A diagram on the right shows the effect of thrust amplitude and thrust duration of an HVT on the response of lumbar paraspinal muscle spindles to a change in vertebral position. Data are reported as means, and 95% confidence intervals, lower and upper, 95% confidence interval. BW is body weight. According to Bicalho, 2002, biomechanical changes caused by spinal manipulation are thought to have physiological consequences, by means of their effects on the inflow of sensory information to the central nervous system. Muscle spindle afferents and Golgi tendon organ afferents are stimulated by spinal manipulation. The graphs on the right shows examples of responses from primary, left column, and secondary, right column, lumbar paraspinal muscle spindle afferents for the 400 milliseconds, top row, 200 milliseconds, middle row, and 100 milliseconds, bottom row, manipulative thrust durations. Each panel shows the displacement caused by the thrust, top trace, and instantaneous discharge plots obtained from original recordings of action potentials, bottom plot. The starting time of the x-axis is arbitrary. All recordings were preceded by a 10 seconds control period. Note: for the 25 milliseconds thrust, the x-axis is expanded. Conclusions. Spinal manipulations with HVT produce increased EMG activation when resting in both paraspinal and distant muscles. Modulation of neuromuscular responses. Reduced muscle inhibition and increased force. Increased paraspinal neuromuscular spindles discharge when resting. Increased stability of the segment of the spine. Increased afferent stimuli, which improves motor response. Reduced muscle spasms in patients with low back pain. Stimulation of the neuromuscular spindle afferents and Golgi receptors. Here you can see a list of all the references used for this presentation. Thank you for listening.